Today's topic is fluid and electrolyte balance. Daily we consume about 2 liters to 2.5 liters of water. So water constitutes an average of 50 to 70% of total body weight. In young males, it's about 60%. In older males, as your age increases, your water percentage decreases. So that's what it is. In infants, it's highest from 75 to 80%, gradually decreases at 1 year of age. The functional components of the body fluids, the water of the body make up about 50 to 70% total body weight. So an average of 60% can be assumed. Intracellular fluid is 40% of the body weight or 67% total body. Extracellular fluid is 20% of body weight or 30% total body water. Interstitial fluid is about 25% total body water. Intravascular fluid is about 8% of total body water, 5% of body weight. Now this is just a graph for you. As we can see, babies have higher percentage of water in their body. Alright. So this is homeostasis, the amount of water which we drink or which we absorb, okay, is equal to the amount of water we excrete, okay, or we discard per day. So obviously urine, this is the, we discard water 1.5 liters a day via urine, right, and we take 2.2 liters of water per day via food and drinks. Output will be equal to, that's all. The fluid movement among compartments, this compartmental exchange is regulated by osmotic and hydrostatic. This osmotic pressure is due to this plasma proteins, okay. Now extracellular and intracellular fluids, exchanges between this interstitial and intracellular fluids are complex, okay. There is two-way water flow. Now, extracellular and intracellular fluids, ion fluxes are restricted and moved selectively by active transport. These ions require active transport, they can't diffuse passively. These nutrients, respiratory gases and wastes, they move unidirectionally. Plasma is the only fluid that circulates throughout the body and links external and internal environments. Osmolarities of all body fluids are equal. Changes in solid concentrations are quickly followed by osmotic changes. Now, osmolarity and osmolality is different. Osmolality is per kg of the fluid and osmolarity is per liter of the fluid. Thirst and satiety. We have some this thirst control hypothalamus which control the release of ADH. Alright. So they will determine whether we are going to drink some water or not, or whether just this will help or not. And the factors controlling urine volume. Blood pressure. An increase causes a greater rate of filtration, obviously. Increased concentration of salts or glucose in blood. It results in decrease in urine output, obviously. Decreased plasma protein, it decreases the urine output. Vasopressor hormone, it prevents diuresis. In water loss from other sources, urine volume varies inversely with perspiration or sweating or diarrhea. Diuretics, it promotes diuresis. Now this is the ADH regulation of urine output. This is the posterior, posterior part of this pituitary lobe, This posterior part, it releases ADH. This posterior lobe of pituitary, it releases ADH and oxytocin. So this is just the pathway. I will share the slide with you later. You can see from it. Now composition of body fluids. So water is a universal solvent. We all know. Solids. Solids can be electrolytes or non-electrolytes. Electrolytes are inorganic salts, acids and bases, and some proteins. Non-electrolytes. Most non-electrolytes are organic molecules like glucose, lipids, creatine, and urea. Electrolytes have greater osmotic power than non-electrolytes, and water moves according to osmotic gradients. Okay, water actually moves according to this one, sodium. Wherever sodium moves, you will see later. These are some of the electrolyte composition of intracellular and extracellular fluid. Like sodium is the most important ion in interstitial fluid, and potassium is the most abundant ion in intracellular fluid. Okay. So extracellular is sodium, intracellular is potassium. Anions. So intracellularly the most important anion is this one, phosphate. Phosphate buffer, we will learn about it later. And extracellular, the most important anion is chloride. Now, osmotic activity of fluids. Concentration of osmotically active particles is expressed in osmoles. Osmolarity in milliosmoles per liter of solutions. Osmolality is milliosmoles per kg of water, and osmolality defines concentration of the solution. Now, body fluid disturbances can be classified into three broad categories: changes in volume, that is hypovolemia. Hypovolemia means decreased volume, hypo is increased volume. Changes in concentration will be hyponatremia and hyponatremia. Mainly hyponatremia is used for low sodium levels, and hyponatremia is for high sodium levels. And changes in composition, like acid-base imbalances and body fluid disturbances can be changes in composition, acid-base imbalances, and concentration changes in calcium, magnesium, and potassium. Signs and symptoms of fluid volume imbalance. Hypovolemia, poor skin turgor, dry mucous membrane, dry axilla, flat neck veins, tachycardia, hypotension, weight loss, and sunken eyes. In hypervolemia, you'll have shortness of breath at rest and exertion because there might be edema. In hepatotubular reflex will be more prominent because of hypervolemia, obviously. More amount of blood which is flowing through the body, there will be prominent hepatotubular reflex. In ascites, pitting edema, weight gain. This ascites pitting edema is this edema only. What are the common tests to evaluate body fluid disturbances? For hypovolemia, you can go for serum electrolytes, creatinine, serum urine nitrogen, hematocrit, urine electrolytes on specific gravity, serum albumin, infrared urine for creatinine clearance. And for hypervolemia, serum electrolytes, the same things. Then you can also go for total protein, cholesterol, liver enzyme, and bilirubin. Now, goal of fluid maintenance therapy. The goal of fluid maintenance therapy is to replace fluids lost normally during the course of a day. Standard recommendations are for 0 to 10 kg, 4 milliliters per kg. For 11 to 20 kg, it will be 2 milliliters per kg. For more than 20 kg, it will be 1 milliliter per kg. Sodium in blood, normal level is as there's a chart I will share with you. Normal level is around 130 to 145 milligram per liter. It's the most abundant electrolyte in the extracellular fluid. Alright. So sodium salts, they account for 90 to 95% of all solids in this ECF. They contribute about 280 milliosmoliters of the total 300 milliosmoles ECF solids concentration. It's regulated by dietary intake, aldosterone, and kidneys. This is the RAS system, renin, angiotensin, aldosterone system. Alright. Angiotensin is converted to angiotensin 1, which is then converted to angiotensin 2. Then it will lead to excess aldosterone secretion. Okay, then tubular sodium, this reabsorption and potassium excretion. Alright, this will also lead to sympathetic activity. Increase sympathetic activity, which will increase the blood pressure. Then arterial vasoconstriction, increase in blood pressure. All this will lead to increase in blood pressure only. In case of high BP and high osmolarity, this is how the homeostasis is supposed to be restored. There will be increase this natriuretic peptide release will lead to decreased aldosterone release, decreased ADH release, and decreased thirst. So there will be decreased water intake, increased urinary water loss, and increased urinary sodium loss. In this way, homeostasis will be restored. Now, hyponatremia. Signs and symptoms of hyponatremia are hyponatremia is when sodium is less than 135 milligrams per liter. The signs and symptoms are confusion, lethargy, coma, nausea, vomiting, headache, and seizures. These are some of the etiology and management of hyponatremia. Okay, like it's isoosmotic. Okay, there will be pseudohyponatremia, hyperlipidemia, and hyperproteinemia. Treatment is correct the lipids and protein levels. Hyperosmotic. Etiology is hyperglycemia, hypertonic solutions. Treatment is correct hyperglycemia, discontinue hypertonic fluids. These are some of the. I will share the chart with you. It's okay. Now, acute versus chronic treatment. Acute serum sodium, if it's less than 110 or 150 milligrams per liter, you will get symptoms like seizures and coma. Rapid correction will be required till serum sodium is 120 to 125 milligrams per liter. If it is asymptomatic, then gradual correction over 48 hours can be done. If it's symptomatic, then you can do rapid correction till 120 to 125 milligrams per liter. Now, hyponatremia. Hyponatremia is defined as serum sodium greater than 145 milligrams per liter. Signs and symptoms are confusion, lethargy, coma, seizures, and hyperexia, much like hyponatremia only. Now, etiology is this chart when hypervolemic, isovolemic, and hypovolemic. Hypervolemic acquisition of hypertonic sodium containing solutions. It will be iatrogenic. The treatment is diuretics. So you give diuretics, it will lead to this one, normal isovolemia. It will lead to this normal atremia. And isovolemic, insensible skin and respiratory loss, diabetes insipidus. So treatment is water replacement. Now, if hypovolemic hyponatremia, the causes will be renal losses, GI losses, respiratory losses, and profuse sweating and adrenal deficiencies. Treatment is isotonic NaCl, sodium chloride, and then hypotonic saline. For correction of hyponatremia, you are supposed to treat the underlying cause. If it's asymptomatic, then give 5% dextrose in water, 0.45% saline preferable in hyperosmolar diabetic coma. Okay, we have diabetic ketoacidosis, and there's another thing which is hyperosmolar diabetic coma. There we are supposed to give 0.45% of saline. Now, very large volumes of 5 liters a day may be needed to be given, but usually 0.45% is enough. If it's symptomatic, then symptomatic में क्या होता है? Your serum sodium will be more than 160 milligrams per liter and serum osmolality more than 250. Normally you want around 300, but here it will be more than 350 milligrams. So what we will give here? 0.9% saline to correct volume deficit after volume restoration change to hypertonic IV fluid. Okay. In correct over a period of 48 hours, as rapid correction may lead to cerebral edema. Yeah, you have to prevent cerebral edema, whatever be the status of the patient. The rate of correction of plasma osmolality should not exceed 2 milliosmoles per kg per hour. Okay. Overly excessive correction may lead to central pontine malinosis. Okay. Malinosis. Potassium, major cation in intracellular compartments, as we already know. Sodium was the major cation in extracellular compartment. In intracellular compartment, it's potassium. It regulates metabolic activities, necessary for glycogen deposits in liver and skeletal muscle, transmission and conduction of nerve impulses, normal cardiac contraction and skeletal and smooth muscle contraction. It's regulated by dietary intake and renal excretion. Normal levels are 3.5 to 5.1 milliequivalents per liter. Body conserves potassium poorly, and increased urine output decreases serum potassium level. Hypokalemia. When we call it hypokalemia, when the serum potassium is less than 3.5 milliequivalents per liter. Signs and symptoms of hypokalemia are neuromuscular, which are muscle weakness, paralysis. Yeah, see, this in hyponatremia, your signs are morely neurological. This one, in hypokalemia, your signs and symptoms are mainly musculoskeletal. Okay, so here neuromuscular is muscle weakness, paralysis, rhabdomyolysis, and hyporeflexia. In GI, you will have paralytic ileus, in renal polyuria, polydipsia, and cardiac EKG findings like ECG findings like T wave flattening, inversion, D wave, and ST depression. Cardiac toxicity or digitalis. The causes are decreased dietary intake, GI losses, renal losses, and cellular. Treatment for hypokalemia initially is aimed at correcting the existing metabolic abnormalities. Like if you have any existing metabolic abnormality, your focus should be on correcting them instead of just the hypokalemia. Potassium chloride is this potassium chloride or pot chlor, which we say sometimes, is administered at 10 milliequivalents per liter per hour peripherally or 20 milliequivalents per liter per hour centrally if ECG changes are present. Hypokalemia alone rarely produces cardiac arrhythmias. Oral supplements can be given. Increased intake of fresh fruits and vegetables or potassium supplements of 20 to 40 millimoles daily. This increased intake of fresh fruits and vegetables is debatable. We give potassium supplements. Patients with high renal losses, for them we use potassium sparing diuretics like spironolactone. For these patients with high renal losses, we won't use diuretics like this one. This loop diuretics we won't use. Okay, we'll use potassium sparing diuretics like spironolactone or eplerenone. Now, in emergency situation, 20 to 40 milligrams per hour of potassium can be given with frequent monitoring of cardiac status and serum potassium levels. In non-emergency situations, 10 milligrams of potassium per hour may be given. Glucose-free solutions should be given as glucose drives potassium intracellularly. Okay. So in the absence of specific indications, potassium should not be given to oliguric patients, those who produce less amount of urine per day, and during the first 24 hours following severe surgical stress or trauma. Now, hyperkalemia when potassium is more than 5.1 milliequivalent per liter. Signs and symptoms are neuromuscular, like previous, weakness, spasticity, flaccid paralysis. It won't be spastic, it will be flaccid paralysis. Okay. Then cardiac ECG findings like peaked T waves, flattened P waves, prolonged PR, widened QRS, ventricular fibrillation, and cardiac arrest. Causes of hyperkalemia are pseudohyperkalemia, transcellular shift, impaired renal excretion, excessive intake, and blood transfusions. Blood transfusions is a thing. Blood transfusion may lead to hyperkalemia, so you may have to look for it while you are transfusing blood. Okay. So treatment could be calcium gluconate or sodium bicarbonate. Glucose and insulin can also be used for this thing. Transferring potassium to inside cells. And sodium polysaccharide are used. Okay. You remember calcium gluconate, sodium bicarbonate, and glucose and insulin. Management of severe acute hyperkalemia when potassium is more than 7 millimoles per liter. You have to identify and treat the cause. Okay, you have to find out the cause of the hyperkalemia and then you have to treat accordingly. Then we have to check for renal function. 10 to 20 ml of IV 10% calcium chloride or calcium gluconate over 10 minutes in patients with ECG abnormalities. That is 10, 10, 10. This one. 10 ml IV 10% calcium gluconate over 10 minutes in patients with ECG abnormalities. 50 ml of 50% dextrose plus 10 units short acting insulin over 2 to 3 minutes. Then monitor plasma glucose and potassium over next 30 to 60 minutes. We may also give regular salbutamol nebulizers. Okay, this beta blockers, they also help in acute hyperkalemia. Okay, then we can also give oral or rectal calcium. Resonium and hematolysis may be given for this thing, persistent hyperkalemia. On calcium. Calcium is stored in bone, plasma, and body cells, 90% in bone, small percent in extracellular fluid. In plasma, it binds with albumin. It is necessary for bone and teeth formation, blood clotting, etc. etc. Normal levels are 4.5 to 5.5 milligram per liter or 8 to 11 milligram percent. Yes, 8 to 11 milligram percent. Remember that. It's regulated by calcitonin, parathormone, and calcitriol. Hypocalcemia when calcium is less than 8.5 milligram per deciliter. Signs and symptoms hypotension, laryngeal spasm. You get spasms mainly when there is this calcemia. Spasms and tetany. And paresthesias, pathological fractures and tetany. You may get Shostak's sign and Trusch's sign. Then anxiety, depression, maybe even psychosis. Etiology, the causes could be hyperalbuminemia, hypoparathyroidism, vitamin E deficiency, pancreatitis, alkalosis, and massive blood transfusion with citrate. In adults who have normal renal function, calcium replacement is 1 gram in 50 milliliter dextrose, 5% in water, or normal saline. IV solution should be infused over 30 minutes. Now, hypercalcemia, when calcium is more than 10.5 milligram percent. Okay. A frequent symptom of underlying disease with excess bone resorption and release of calcium. Okay. This is a frequent symptom of underlying disease with excess bone resorption and release of calcium. Like examples could be Paget's disease, osteoporosis, hyperparathyroidism, malignant neoplastic disease, prolonged immobilization, and acidosis. Signs and symptoms include anorexia, nausea, vomiting, weakness, and kidney stones. Diagnosis: radiographs show this bone X-rays will show bone resorption, and there will be some cardiac irregularities. Treatment includes hydration with normal saline, bisphosphonates, calcitonin, glucocorticoids, and phosphates. Now, magnesium balance. Normal concentration of magnesium is around 1.5 to 2.4 milligram percent. It is essential for proper functioning of enzyme systems. The depletion is characterized by neuromuscular and CNS hyperactivity. Hypomagnesemia is greater than 1.8 milligram per deciliter. Signs used to be less than 1.8 milligram per deciliter. Now, signs and symptoms include arrhythmias, prolonged PR and QT intervals on ECG, hyperreflexia, fasciculations, and Shostak's and Trusch's signs. Okay, much like calcium only. The magnesium replacement, if it's less than 1.5 milligram per deciliter, then give magnesium dosage 1 milligram per kg. If it's 1.5 to 1.8, then give 0.5 milligram per kg. Hypermagnesemia is serum magnesium greater than 2.3 milligram per deciliter. Signs and symptoms include respiratory depression, hypotension, cardiac arrest, nausea and vomiting, hyperreflexia, and somnolence. Increased sleepiness, that's what somnolence means. Treatment for hypermagnesemia may include calcium infusion, saline infusion with a loop diuretic, or dialysis. Now, phosphate. Remember, phosphate is the most important anion intracellularly. Now, hypophosphate normal value is 2.5 to 4.9 milligram per deciliter. Now, hypophosphatemia is serum phosphate less than 2.5 milligram per deciliter. However, symptomatic hypophosphatemia is usually less than 1 milligram per deciliter. Signs and symptoms include lethargy, hypertension, irritability, cardiac arrhythmias, and skeletal demineralization. Treatment: if it's mild, that is 2 to 3, then you can give 0.16 millimeter per kg over 4 to 6 hours, diluted in at least 100 ml. If it's moderate, that is 1.6 to 2.2 milligram per deciliter, then you can give 0.32 millimeter per kg, milliliter per kg over 4 to 6 hours. Milliliter it should be, yeah. And if it's severe, less than 1.5 milligram per deciliter, then 0.64 milliliter over 8 to 12 hours. Now, hyperphosphatemia is defined as serum phosphate greater than 5 milligram per deciliter. Pruritus is the only remarkable symptom of hyperphosphatemia. Treatment includes dietary phosphate restriction, phosphate binders like calcium acetate or carbonate, and hydration to promote excretion of the phosphates. D50 and insulin may be given to shift phosphate into the cells. Now, extracellular fluid excess. We have extracellular fluid, we have intracellular fluid. Okay, extracellular excess, ECF excess happens in renal insufficiency, chronic heart failure. It could be arterogenic, it could be cirrhosis. It could be drugs like NSAIDs and mineralocorticoids. It could be because of this dilution of ECF, like sodium content is normal but excess water is present, which is known as hypotonic hydration. The resulting hyponatremia promotes net osmosis into tissue cells, causing swelling. These events must be quickly reversed to prevent severe metabolic disturbances, particularly in neurons. Now, ECF deficit. The causes are loss of GFS due to vomiting, diarrhea, nasogastric suction, or fistula drainage. Vomiting and diarrhea, you remember. That's all. Soft tissue injuries and infections, intra-abdominal and intraperitoneal inflammatory processes, burns is important, insensible losses, and sweat. Clinical evaluation. Changes in body weight should be recorded accurately and repeatedly on a day-to-day basis. Weight loss more than 300 to 500 grams per day indicate dehydration secondary to decreased fluid intake and or increased water losses. Now, if If it's water loss is 4% of body weight, then it's mild dehydration. If it's 6% of body weight, it's moderate. If it's 8%, it's severe. Now, crystals and colloids, okay, both of them have their pros and cons. These are the fluids which may give to patients who have dehydration. This intravascular persistence, it's poor, and it's for colloids it's good. Required infusion volume, okay, for crystals it's large, for colloids it's moderate. Now, enhancement of capillary perfusion, for crystals it's poor and colloids it's good, and for plasma colloid osmotic pressure, for crystals it's reduced, and for colloids it's maintained. Now, volume resuscitation, when blood loss is mild, less than 15% of blood volume, no volume resuscitation is necessary. With moderate to severe blood loss, the vascular space must be filled with to support cardiac output. The only effective management of hypovolemia is volume resuscitation with crystals or colloids, rather than blood transfusion. Doesn't matter. Colloids are large molecules that do not diffuse across membranes readily. They are efficient plasma expanders. Okay. Now, some plasma expanders are L-butene 5%, L-butene 25%, buminate, plasmanate, plasmatine, plasmaplex, butynate, and dextran, and it is hexastarch. Disadvantages of these colloids are it may result in hypertension secondary to decreased systemic vascular resistance. This administration of hexastarch and dextran in large volumes can result in dilution of coagulopathies. Hexastarch, when administered in greater than 1 liter in a 70 kg patient, can precipitate a decrease in factor 8. Okay, that's right. To lead to coagulational problems. And dextran can decrease platelet adhesiveness and may cause an anaphylactic or an anaphylactic reaction. In addition, dextran also facilitates the agglutination of red blood cells. Now, electrical composition of commonly used RB solutions is normal saline, 0.9% is normal saline, 0.45% is this bi-to-normal saline, then 0.33 NaCl, 0.2% NaCl. Reverse lactate, okay, reverse lactate is very important. Remember that 3% hypertonic salines, which includes 3% and 5% NaCl. Indications of blood therapy: if crystals and colloids don't work, you may have to give blood. The indication for blood transfusion is to increase the oxygen carrying capacity of the blood. Blood transfusion almost always indicated for hemoglobin less than 6 grams per deciliter. Some say 6, some say 5, so whatever, just you can write 5 or 6 grams per deciliter. Okay. The decision to transfuse blood, however, never is based solely on the hemoglobin concentration. Acute loss of volume greater than 40% of patients' total blood volume or acute loss linked to hypovolemic shock usually necessitates blood transfusion. Now, method for determining resuscitation volume sequence. Estimate the normal blood volume, estimate percent loss of blood volume, and calculate the volume deficit. Also, determine the resuscitation volume. Okay. So this is the formula which you can use. I will give it to you later. Now, blood component therapy. Transfusion with whole blood rarely is indicated. Components obtained from whole blood include PRBCs, packed red blood cells, platelet concentrates, FFPs, cryoprecipitate factor VIII, albumin, PPF, leukocyte, poor blood, and antibody concentrates. Blood components are preferable to whole blood for several reasons. Component therapy allows specific deficiencies to be addressed, preserves the remaining whole blood components, allows longer storage, and reduces the risk of transfusion reaction. These are the complications of blood product usage. Transfusion reactions, okay. It could be febrile, allergic, or hemolytic. Okay. Then coagulation disorders could be dilution or thrombocytopenia, factors 5 and 8 deficiency, and disseminated intravascular coagulation. Then metabolic abnormalities like hyperkalemia, hypocalcemia, metabolic alkalosis, hypothermia, acute lung injury like or ALI, and macroaggregates. Autologous blood usage. This autologous blood donation is possible for healthy patients scheduled for surgery in whom significant blood loss is expected. A common collection protocol is donation of 1 unit of blood every 4 days for a maximum of 3 units. The last unit must be donated no sooner than 72 hours before the surgery to restore plasma volume. Intraoperative blood salvage. This involves the collection, washing, and storage of red blood cells by a semi-automated system. The hematocrit of salvage blood is between 50 to 60%, and the pH is alkaline. Contraindications include blood-borne diseases, malignancy, and contamination. Hemodilution involves the removal of arterial or venous blood preoperatively, followed by plasma volume restoration with crystalloid or colloid fluids. The blood then is stored in the open operating room and transfused to the patient after cessation of bleeding. This procedure may be used for surgeries in which intraoperative blood loss of 2 or more units is anticipated. Now, blood products do not increase blood flow adequately and in some cases impede flow as a result of increased viscosity. Therefore, crystalloid and colloid fluids should be the initial management strategy for volume resuscitation in acute hemorrhage. So, before giving blood, you should always consider crystalloid and colloids. Now, favorable clinical response include the following plans: CPV is 50 millimeter per of mercury, PCWP should be 10 to 12 millimeter of mercury. Adequate heart rate, cardiac index should be 3 liter per minute per meter square, and urine output greater than 1 milliliter per kg per hour. Now, what would be used for dehydration? In normal healthy individuals, it could be oral route. However, when rapid correction of hypovolemia and other electrolyte abnormalities is indicated, then IV routes provides a quick access to circulation. Other routes include subcutaneous and per rectum. This fluid and electrolyte management in burn patient. The goal of fluid management in major burn injuries is to maintain the tissue perfusion in the early phase of burn shock, in which hypovolemia occurs due to steady fluid extraposition from the intravascular compartment. Burn injuries less than 20% are associated with minimal fluid shifts and can generally be resuscitated with oral hydration, except in cases of facial, hand, and genital burns, as well as burns in children and the elderly. The formulas, these are some of the commonly used formulas which are used for fluid resuscitation in major burns. Parkland, Brook, Evans, and Monafos. Parkland and Brook, you remember. Parkland formulas. This Ringer's lactate is the which should be used in burns. Ringer's lactate solution 4 ml per kg per percentage burn for adults and 3 ml per kg per percentage burn for children. 4 ml per kg per hour for children weighing 0 to 10 kg. 40 ml per hour plus 2 ml per hour for children weighing 10 to 20 kg, and 60 ml per hour plus 1 ml per kg per hour for children weighing 20 kg or higher. This formula recommends no color in the initial 24 hours. Next 24 hours, colors given to nearly 60% of calculated plasma volume, no crystalloids. Glucose in water is added in amounts required to maintain a urinary output of 0.5 to 1 milliliter per hour in adults and 1 liter per hour in children. Now, Brooks formula. Okay. Initial 24 hours, Ringer's lactate solution 1.5 ml per kg per percentage burn plus colloids 0.5 ml per kg per percentage burns plus 2 liter glucose in water. Next 24 hours, Ringer's lactate 0.5 ml per kg per percentage burn, colloids 0.25 ml per kg per percentage burn, and the same amount of glucose in water as in first 24 hours. Now, Evans formula. First 24 hours, colloids 1 liter per kg per percentage burn plus colloids at 1 liter per kg per percentage burn plus 2 liter glucose in water. In next 24 hours, we may give crystalloids at 0.5 ml per kg per percentage burn, colloids at 0.5 ml per kg per percentage burn, and the same amount of glucose in water in the first 24 hours. That is this one. And the choice of fluid. The ideal burn resuscitation is the one that effectively restores plasma volume with no adverse effects. Isotonic crystalloids, hypertonic solutions when given. Colloids have been used for this purpose, but every solution has its advantages and disadvantages, and none of them is ideal and none is superior to any of the others. So ultimately, the fluid which we use for most of them is Ringer's lactate. Ringer's lactate is the fluid of, we may say that Ringer's lactate is the fluid of choice in burns. These are some of the algorithms on how to replenish fluids in a patient. This you may take from me later. Alright, thank you. The class is over, you may go to your ortho class now.